How do we keep control of cost in healthcare? How do we improve access to healthcare? And how do we make sure quality of healthcare is high and strong? Black Opal invests in what we say the collision of healthcare and technology. So we invest in companies that are either applying or developing highly innovative technology to healthcare and life sciences, and we invest in all the frontier technologies that have applicability in this industry. The mission of the fund is to have significant returns, but have positive impact both on the industry that we invest in and on the venture capital ecosystem. My dream is that we get the right care to the right patient at the right time at an affordable cost. And if we can start to do that in ways that make it easy for patients, that is a vision of healthcare that I would love to see. That happens in certain situations and certain circumstances, but we have so much more to do.
Tara, we're rolling now, and thanks for coming on the show. I'm been really excited to get together with you today. Your story seems kind of wild. You went from being a doctor to running a successful health tech VC fund, and that's not the normal route there. And even your road to being a medical doctor wasn't exactly a straight line. But before we dive into Black Opal Ventures, I always like to start at the beginning with my guests, and I mean the real beginning. So I'd like to know a little bit about your childhood and where you grew up, and a bit about your parents and your family, and any formative experiences that might have influenced your path to becoming a medical doctor and then on to venture capital, of all things.
There are many things in my early childhood and my high school years that were very formative in terms of developing my career. So I'm the daughter of two physicians. My parents are both doctors.
That's where the doctor bit comes in, huh?
Yeah, the doctor bit comes in very early in life. And actually, from my father's side, I'm actually the fourth generation of physicians in the family. So his father was a doctor, his grandfather was a doctor. But my parents immigrated here in 1971 from Sri Lanka. And at the time, they had just gotten married. They had just finished medical school. And they came over to the States to do 1 year of internship. And the plan was that they would do a year of internship and then go back to Sri Lanka. They ended up staying their whole lives here. And they ended up in Massachusetts. My mother has these stories of her showing up and never seeing snow before, never seeing the cold before, and starting the rigorous process of being an intern in the U.S. healthcare system. They had practice. They actually moved over to New Haven, Connecticut in the 1970s when I was born, and I was born in New Haven, Connecticut. We lived in a suburb of New Haven almost my entire life. And both my parents were internal medicine doctors. They actually had a practice together in a town called West Haven, Connecticut, that was just outside of New Haven. And my mother actually was a person that started the practice in the 1980s. I think that experience of having, a mother who was a full-time working physician was really influential on my life. She was one of the very few female physicians at the time. She had started this new practice, was on her own, starting her own business, and it was a very successful practice. She actually, I think, found a niche of people that wanted to see female physicians. And before she knew it, she got too busy to handle all the volume that was coming her way. And so a few years later, my father actually joined her practice. And so they became this dual physician couple owning a practice together. And so as you might imagine, everything in my home growing up was around medicine. It was around what was happening in the practice. It was around what was happening from a doctoring perspective. And so we were just surrounded by medical, doctoring and the medical profession my entire career. And there was obviously, I think, not an expectation, but a hope that at least some of my parents' children would go into medicine. I ended up being the one that did become a doctor. I have two brothers, an older brother and a younger brother, who interestingly work in healthcare but are not physicians. And so there was definitely a hope that we would at least some of us would become physicians, having come from a family of physicians. I ended up going to MIT for undergrad, which is not, I think, the most common undergraduate university that people think of doctors coming from.
You went to Hopkins in New Haven from the seventh grade on, right?
So Hopkins is an amazing kind of preparatory school in New Haven, Connecticut. I moved from the local public school in my town to Hopkins in seventh grade, and it was a beautiful New England campus school, had some amazing teachers, particularly in math and science, that were very influential in my career and influential in my love of math and science. And so that was, I think, the time when I realized I really like math and science. I probably less so on the humanities, history, and English were not my strong suits. But I found this place where I could really strive in the math and science fields. And that, again, was, I think, a formative area where I realized I wanted to study something that was in the scientific field.
Right. And then around 1993, you went to MIT and ended up studying chemical engineering, of all things. I guess that kind of makes sense with your interest in maths and sciences, but chemical engineering is not exactly where everyone goes. Tell me what was going on in your world that made you focus on that. You know?
Right. I don't know if every 16-year-old is thinking about a career in chemical engineering when they're growing up. I was very fortunate in 1990. It was actually 1992, the year before I graduated. I got into MIT as an early action student, sort of amazed and shocked and excited to have that opportunity. And when I graduated in 1993, I went on to join the university in the fall. I thought I would study biology. I definitely had in my mind that I was going to probably be a doctor. I had all these influences in my life. It was certainly something I had been considering from a very young age. But I got to MIT and I realized that so many people at MIT were engineers, and the caliber of the engineering education and the research and the professors was just amazing. And I decided freshman year that I wanted to do something that was at the intersection of biology and engineering. And it turned out that chemical engineering was a very applicable field to that concept of being able to tie in biology and engineering. Now, this was like the 1990s, and obviously the world is so different now. But in the 1990s, we were just starting to understand biology. We were, starting to understand the genetic code. We were starting to understand all these things in biology, but it was very early on. And I actually found in chemical engineering, there was a lot of applicability of things like how do you make pharmaceuticals? How do you process things that have applicability in medicine, and tying in that with my what was happening on the biology side. So I actually majored in chemical engineering, but then did a minor in biology. And then I actually double majored in music.
What kind of music?
I was a singer in high school and in college. I did both sort of musical theater and also choral music at the time. I had done a lot of musical theater when I was in high school and decided I wanted to do more of that in college, but also take coursework on it. And I found that I really enjoyed mostly the theory of music and the idea of actually, it was almost mathematical when you think about music, right? Chords go together, there's rhythm, there's beats. And I found that was a wonderful way to apply some of my interest in math and science, but also apply it to a field that was more creative. And I started doing a little bit of composition work, not a lot, but learning how to do that, and really enjoyed those subjects. So I kept pursuing that. And so I graduated with a double major in chemical engineering, music, and a minor in biology.
Well, telling me about the music major is a little bit dangerous because I have to ask you for a tune.
Oh, well, the sad part, Scott, is I think this happens when we start careers, when we start families. I have not done anything really in music since I graduated from college. I went straight to medical school that took over my life, but I am hoping that I can, this is something I can pick up as I get a little bit older, my kids start to leave the house.
Were you trained in music during your primary education?
And actually, it's interesting because that influence of my family, we talked a lot about my parents being doctors, but my family was very musical. So my grandmother was a music teacher, a pianist. My mother was a pianist and a doctor. And so there was a big influence of music in my life growing up. So I studied the piano. At some point in my teenage years, I quit the piano and then moved on to do more singing and musical theater when I was in high school. And that was my outlet, my social life. It was a wonderful way to have a balance of all the academic work I was doing. And at MIT, I found quite an amazing community of musicians, and then was able to do coursework to augment that.
And why MIT? Obviously, it's a good school, but it's relatively close to where you grew up. Is that so you could bring your laundry home on the weekends, or what?
I wish I could. It was a little too far to bring my laundry home every weekend. But my parents, really wanted me to be within driving distance. And so when I looked at schools, I had sort of this radius of Boston to Washington, anywhere in between that. Fortunately, there are so many schools in New England that I could look at. But I really, obviously the education and the academic work was appealing to me, but I really wanted to be in a city. And so I started to look at schools in more metropolitan areas, ended up really falling in love with Boston when I looked at colleges. And I had grown up in a suburban environment, wanted to be in more of an urban environment for college, and ended up wanting to go to Boston.
Now, what's fascinating to me is this transition you made from chemical engineering to medicine. That's not a typical path. What was going through your mind when you decided to make that pivot to go to med school and to go to Cornell?
So when I was an undergrad, it's interesting because you're right. Most people don't think of a chemical engineer as being someone who go into medicine. But what's interesting is there were so many things that were being applied chemical engineering that applied to medicine. So when I was an undergrad, I started to take very classic courses in chemical engineering, thermodynamics and fluid dynamics, and all these things that were very engineering focused. But as I got into my more senior years, I was able to specialize and do research in areas that were, again, at the intersection of chemical engineering and biology. And so I spent a summer and several academic years working in a lab at MIT with a professor named Bob Langer. And Bob Langer is a professor who was really instrumental in developing new ways that we could deliver medications. And he took that and moved that on into the biotech world and became one of the founders of Moderna, which is a big pharmaceutical company. And so I had this exposure of how do you take engineering, apply it to medicine, and then see the impact of that on patients. Again, in the back of my mind, I had always thought that I would probably go to medicine. And so by the time I was a junior, I was studying for my MCATs and taking courses and, doing all the things to get my application going for medical school. And then I applied my senior year of college and was fortunate to get a spot at Cornell. Again, I think there's a little bit of that urban desire in my life. I wanted to move from Boston to an even bigger city, and New York was an amazing city to be in. And obviously Cornell was an amazing medical school to attend.
All the while staying within that radius that your parents drew
I know.
the circle around.
Someday I might move, but yes, I haven't been able to get out of these Connecticut, Massachusetts, or New York in my whole life.
And then once you got out of med school, your early career was spent entirely in medicine. Starting around 2002, you did your residency at Mount Sinai Hospital. So walk us through those first years as a medical resident and then later as a fellow. What was that experience like?
I think you alluded to this earlier, Scott. I've had a very wavy career path, even from the early days of my career. So yes, I did have a traditional career where I moved from medical school into residency at Mount Sinai. And Mount Sinai is a big academic medical center here in New York City. This was in 2002. A few things were happening at that time. I mean, this is, 20 years ago in healthcare. As a resident, you start to see a lot of the problems and issues that happen in healthcare, more so than when you're a medical student. You're sort of isolated and a little protected from everything. But I remember in 2002, I started my residency. I didn't know what I wanted to do. I thought I might specialize, I might practice full time. And then very quickly, I realized that there were a lot of problems in healthcare. And it was really frustrating for me to practice in this world that felt totally broken. We had patients who would leave the hospital, show up the next day, get admitted, leave the hospital, show up the next day, get admitted. And it was this revolving door of certain patients, particularly vulnerable patients. We had a lot of patients who didn't have health insurance because we didn't have a lot of the protections of health insurance. Nothing was digitized. So everything was on paper, in charts. I remember spending, hours of my day as an intern looking for charts on the floor so I could read what was happening with the patients, and then trying to interpret what people were writing in these charts because it was so hard to read people's handwriting. That joke that doctor's handwriting is terrible, it was actually really true at the time.
The rule that proves the cliche, huh?
Exactly. Very early on, probably, a few months into my internship, I kind of sat down and I was like, do I just want to practice and be sort of this cog in a wheel of a mess of healthcare? And I really decided that I wanted my career to do something more impactful in healthcare and bigger than just seeing patients on a day-to-day basis. I think there's tremendous value of seeing patients on a day-to-day basis, and I have loved the time that I've spent with patients. But for me personally, it just didn't feel like it would be a sustainable career. And so I went out looking for ways to kind of think bigger about what I could do in healthcare beyond just seeing patients. When I was after my residency, which is 3 years long here in the States, I moved over I stayed at Mount Sinai and did a fellowship in palliative care. And palliative care is a field of medicine that focuses on end-of-life care. And from, again, kind of that bigger healthcare perspective, I found that we were sort of in healthcare in the US, we were doing a lot of sort of care at the end of life that was maybe not so supportive of patients, maybe extending life unnecessarily for patients who might be uncomfortable or in pain, and not focusing on quality of life. And so I felt like palliative care would be an amazing field to be able to tie in that sort of bigger picture impact with the clinical area. Loved the field for a while, but actually found that it was a very hard to practice field. It was quite depressing at times when your day in, day out is working with patients who are at the end of their life. And I worked with some amazing people, but after about 6 months of my fellowship, I realized I didn't want to do that full time. So I actually ended up taking off 2 years after that fellowship. I had my first son at that time and wanted to be home with him, which is also a pretty unusual thing in medicine. You work so hard to get through training. And then I had this little baby at home and didn't want to leave him. And so I actually took off 2 years to be home with my first son. I had my second son at that time, but also realized that I didn't want to be home full time. So I went exploring and trying to figure out what I wanted to do with my life. This is, at this point, I'm almost a decade out of undergrad and I'm still trying to figure out what I wanted to do with my life. And I ended up stumbling into sort of the policy world at that point. Applied and got accepted to do another fellowship at Mount Sinai it was called a General Internal Medicine Fellowship, but really focused on healthcare policy, healthcare research. And I ended up getting my master's in public health through that fellowship, and starting and launching a career that really focused on understanding and addressing a lot of the problems in healthcare and understanding how policy played a role in that. And that really launched me into the work that I do now, that fellowship I did at Mount Sinai.
You went from focusing on end of life to focusing on very beginning of life.
Yes, that's right.
And then your fellowship on policy. This was all at Mount Sinai. Probably thinking you'll be a doctor forever. And then around 2016, McKinsey comes into the picture. And I'm really curious about this transition because consulting is such a different world from clinical practice and actually more like a different universe. So, what sparked that change?
I'll take you back a little bit after my fellowship and the time I spent in academic medicine. So, after Mount Sinai, I moved back to Cornell and became a professor of health policy at Cornell. And it's interesting because in academic medicine, you actually have an opportunity to do wear lots of different hats. And so I spent my time both seeing patients. So I was a primary care physician. I saw patients in the hospital, but only about 20% of my time was actually clinical time. I did a lot of work in research. And so at the time when I joined the faculty in the US, the Affordable Care Act had just been passed. And it was a massive policy change in the US. And we were trying to figure out both what we would be doing with this new policy and how it would impact things. And so I started to do a lot of research on things around access to care and quality of care and how would things like value-based care impact all of these things that were significant problems in the healthcare system. I had this eye on what was happening in the policy world, but also how did we apply that to what we were doing on the ground in the hospital system. So I did a lot of work around quality improvement in the hospital system and ways to sort of improve what we were doing on an operations side in the healthcare system. So, the jump to McKinsey was certainly a big jump, but I wasn't going from 100% full-time clinical work to a job that was very non-clinical work, but it was still a transition. I tell people I grew up in and around hospitals my whole career, and everyone around me was doctors and nurses and health system executives. And I moved over in 2016 to McKinsey, which is an amazing consulting group, but I had never really worked with anyone who came from the business side of healthcare or the business side in general. I came with a lot of on the ground experience, but not that business experience. And so it was, the reason I really wanted to change was I wanted to sort of see if I could apply all that knowledge and experience on the policy and healthcare side to sort of a different area in healthcare. And I found the private sector to be just like an interesting opportunity and challenge for me, and took a jump. Didn't quite know what I was getting myself into.
How did that even come on the radar?
In 2015, I was actually trying to think about sort of next steps for my career. Academic medicine is an amazing set of, a career path, but often what you have to do is publish a lot of articles and write a lot of grants for it to have credibility in the field. And after doing that for many years, I realized that I wanted to do a little more hands-on work rather than having my whole career focused on writing papers and grants. I would just talk to people, and I ended up meeting a woman who had been a Cornell medical student, MD, PhD, who went to McKinsey right after medical school. We started talking about some of the work that they were doing. And one of the things that was really exciting was the work that was happening around value-based care. McKinsey was helping to advise their clients, whether it was health systems or payers, on how to really succeed in this new environment of value-based care in the US. And that was really intriguing to me because I had been sort of writing about value-based care. I had been lecturing about it, but I had never sort of gone out into the industry to try and build value-based care programs. And so that was, it was just I think a set of lucky circumstances of meeting someone at McKinsey, realizing that they were doing a lot of on-the-ground work in value-based care, and that I could bring a lot of value being a practicing physician and an expert in that area.
How do you define value-based care?
And this is a little bit unique, I think, to the U.S. healthcare system. Each country's healthcare system varies quite a bit, but in the U.S., traditionally, we've paid for healthcare based on the things that are done in the doctor's office and the hospital. So if you go see a doctor or you're admitted to a hospital, the insurance company or the patient will just pay for those services. And we call that fee-for-service healthcare. One of the risks of fee-for-service healthcare is that if you do more, you end up making more money. And if there's no sort of monitoring of that or alignment of the incentives, we end up spending a lot of money on potentially wasteful or unnecessary care. And so the concept of value-based care is, what if you actually try to pay differently so that you actually align those financial incentives with better outcomes and better quality rather than just the volume of care that we give. And that's really the key part of value-based care is let's pay for better quality, better outcomes, and not just, the number of procedures you actually or visits you actually do. And that was a big part of the Affordable Care Act, was trying to design new ways of paying for healthcare so that we could drive better quality and outcomes at lower cost.
My research is right. That lasted about 2 years until 2018. To something else I found really interesting is you moved into industry into something called bind benefits. And here you are coming from McKinsey and you step into this, I guess it was a health insurance startup. Is that how you describe it? Right?
That's right.
And you're chief medical officer. What led to that change and what in the world was that like going from big consulting to a startup?
It was an amazing and eye-opening experience to move from a big consulting, name brand, large consulting company, even leaving a big academic medical center like Cornell, very big organizations, to at the time was, I don't know, 30 people at a startup, very, very early on, pre-revenue, pre-customers, where we were just building a product, a new insurance product. And people ask me, why would you leave this big name brand consulting company? And I think part of it was the opportunity to build something from scratch. It's one thing to be a consultant. For many people, it's a very satisfying career, but you end up having to kind of give your advice and then hope that someone will execute on that advice. Your client will execute. And that doesn't always happen. And so the chance to actually go into a company and say, I'm going to actually try to build something from scratch and build something that I thought was going to be really impactful, like really a better insurance product. I think most people don't like their insurance. I'm pretty, or don't understand their insurance, at least historically. And we had a chance to really build something that we thought would be a much better insurance product that would be both satisfying for patients, but also driving value, like as I described, better quality, better outcomes at lower cost. So that experience was amazing. I mean, I showed up and I remember, thinking that you never know what's actually already built at a startup and how much is not built. And, we had to build a lot from scratch. We had our first members on the plan about 6 months after I joined the company. We had to be able to answer questions about benefits and answer questions about who they could see and what would be covered. And we had to design all of that from scratch. So Bind was a company that is now under the United Health Group umbrella, but it was a company that was trying to make the cost of healthcare very transparent to patients so that before you walked in the door, you could know exactly what something would cost you, and you could understand how that would cost if you went to one provider versus a different provider, if you chose one treatment versus a different treatment. And before you walked in the door, you would know exactly what that would cost. That's not how most health insurance works in the US. And we had to build that ability to predict and tell someone what things would cost using data and data science and completely new models of actuarial underwriting, and build that all from scratch. So that was the point of Bind was, we'll tell you exactly what things would cost, and then you can have choices and you can make choices based on those costs to you.
So did they disrupt the market, or was that the idea, or they actually did it?
Yeah. So the idea was like, how do we build a much better health insurance product? And, obviously starting out, it can always be very hard to start out in a new company. You have to kind of compete with incumbents. And we actually sold the health insurance to employers. So employers could buy the health insurance product. We served as the administrator of the product, and then their employees could sign up for Bind. So we had to sell to employers, and then we had to convince employees that Bind was going to be a better offering than, the two other offerings that were available to them. I actually remember in the early days of actually going to sales calls with our sales reps, going to open enrollment meetings where we would meet with employees and help them understand what Bind was doing. Really exciting stuff, but also people were somewhat skeptical, right? Nobody, not everyone wants to take on a brand new health insurance product and don't know, a lot of people don't understand how it all works. But we ended up getting really amazing traction over time, and growing significantly, to the point where, we were competing with many of the large incumbent health insurance companies, and we were getting satisfaction rates that were incredible. People would look at our app and say, I actually, for the first time in my life, know what it will cost me when I actually get all the claims and the bills. It's actually what you told me it would be. And I can plan for my out-of-pocket spending on healthcare, and make decisions based on lots of information that's coming my way. So we were really proud of the product that we built and the impact that it had on transparency for patients, but also on keeping costs down in for all the people who are paying for it.
And what was your role as chief medical officer?
It entailed a lot of things, especially early on. I think for any person who joins a startup in the early days, you're often doing anything and everything. And so I spent the first year of my time at Bind very closely with our benefit design. So we worked very closely to be able to define, as I said, the benefit, like, it'll cost you $10 to go to this provider or $20 to go to this provider for this kind of care. All of that had to be built from scratch. And so I worked very closely with the benefit design team to define the benefit. As we started to grow and scale, I actually then my role transitioned to really doing clinical operations. And that was really working to monitor everything that was happening with our patients and our members. So what kind of care were they getting? Were they navigating care easily? Could we help support them more? Could we make sure that, they were getting the right care at the right time? And so I worked with a team of nurses, a team of care navigators, worked closely with our pharmacy benefits. And so a whole team that was really operating things and monitoring all the things that were happening as we ran the plan.
Were there any insights you gained during that experience about healthcare innovation that later informed your work with Black Opal as a VC investor?
I think probably the biggest thing for me was understanding how you sell into the industry and commercialize a product. Lots of startups are out there that have, I think, great ideas, great product, great technology. But one of the hardest things in healthcare is understanding how you get someone to buy that. It's a very complicated field where, you have health systems, you have payers, you have, all sorts of groups in healthcare, and they all want new technology or new innovation for very different reasons. I think one of the most valuable lessons I had was actually, as I said, working with our sales teams to understand, like, how do you sell something into an industry that's really hard to sell to? And that's probably one of the biggest lessons I got out of my time at Bind, of being really early on and talking to potential customers and understanding what their needs were, understanding why they said no, why they said yes. So that was a big area. I think the other kind of lessons from that is just, how do you start to organize for scalability and growth? As I said, when I first started, I feel like everyone was doing everything. We were, we always joked that we were building the bus as we drove it, constantly, like, realizing something had to be built while we were trying to operate a plan. And that was a constant thing at a startup. But over time, you have to start to think about how you scale that up, and become a more sustainable business. And, I had an opportunity to kind of both learn how to do that, learn the pitfalls of and the challenges of doing that, but really learned a lot around how you go from sort of this very early phase startup to something that actually becomes a more sustainable business operating model.
And that brings us to about 2021, when you founded Black Opal Ventures, which is why we're speaking today. You teamed up with Eileen Tanghal, who you knew way back during your undergraduate years at MIT, and you both somehow decided to start Black Opal Ventures. So What's the story behind the story?
Scott, you alluded to it. Eileen and I actually met, I think maybe the first week of freshman year when we were undergraduates at MIT. So going back all the way back to those MIT years, in 1993, we were, these newbie freshmen ended up joining a living group together and became very close friends during our 4 years of undergraduate. Eileen was an electrical engineer. I was a chemical engineer, so both engineering students. And she had more of I think, a traditional career path in technology and venture, worked in the startup world. She was a venture capitalist for the past 20 years, but we had stayed very close friends and confidants throughout our careers. And in 2019, we were actually with a group of our girlfriends from college. So there's a group of about 10 of us. We get together every year. At this point in our lives, we were all sort of at a period in our careers where we were, successful professionals at sort of high levels of our careers. And we were sort of sitting around talking about what would be the next phase of our careers. And Eileen and I actually we started talking more in depth about this and, realized that almost for the first time in my career and her career that we actually were seeing synergies of our world. So Eileen had been a deep tech investor. She actually was an investor and a senior partner at a fund called InQtel, which is the fund that the investor that supports the intelligence community. So you can imagine that much of the investments she did were very highly technical things like, artificial intelligence and monitoring and all sorts of really technical solutions that could help support national security. And what she was finding was actually a lot of the technology that she invested in had applicability into healthcare. But often the founders didn't know how to navigate healthcare. As I said, healthcare is a really hard industry to navigate. And so they were kind of missing out on this very big market opportunity because it was hard to get into it. On the flip side, I was working at this startup and we were just starting to kind of use data to really change the way we did a health insurance model. And so for the first time in my career, I was seeing, this opportunity to really use these massive amounts of data that we were generating in healthcare to actually have products and technologies that were really changing things in the healthcare side. And so we had this aha moment. We said, you know what, let's start, why don't I start helping your companies? You can start telling me what you're seeing on your end so I can apply that to my job. And then lo and behold, that ended up becoming a thesis for Black Opal Ventures. We actually started investing some of our own personal capital together in tech. And the idea was is there something highly technical that we could invest in that had applicability in healthcare and life sciences? In 2021, we actually had an opportunity to pitch to Eli Lilly and to their venture group. They were starting an emerging manager program, and we got a chance to speak with them. Eileen had known the head of ventures for a long time, and he said to us, why don't you guys start why don't you make this a real fund? There's a real thesis around what you're doing. You're bringing two different vantage points and experiences to the table. And there's a lot of opportunity in healthcare and life sciences to have technology play a big role in that. We both had jobs at the time. I was the CMO at Bind. Eileen was a senior partner at InQtel. She was actually on her way to go to London, do an assignment in London for InQtel. And we had to kind of make a decision about whether we were going to take this opportunity or not. Now, in retrospect, I realize how rare it is to have an opportunity to have a large corporate anchor investor in a fund. But at the time, I didn't quite realize how unusual that was. And so we took a little bit of time to make a decision about whether we wanted to go for this and really start a fund. And it was, not necessarily quite yet on the roadmap. So I actually ended up resigning from Bind and launching the fund on my own in 2022 when we started investing out of our first vehicle. And Eileen joined 7 months later in September of 22 after she finished her time in London with InQtel. And we've been together ever since then, full time at Black Opal Ventures.
Was that the idea that you would start first and then she would follow, or did you say, no, I'm both boots in and she had some more convincing to do, or?
We both had commitments. And so I think the idea, Eileen had just gotten to London. The idea of leaving In-Q-Tel right then was a little, it was a little jarring. So it was mostly like, how could we stagger this in a way that made sense, but allowed us to really get both of us on board at a timing that worked for both of our careers.
After she went through the first winter, then she decided that.
Yeah, right. She went back to California, so that may be the case.
I have to ask, where did the name Black Opal come from?
So the name Black Opal was a little bit of just brainstorming on our end. So one of the things that we wanted to do was we wanted to have the name of a gemstone. We were, a female-led fund. We thought, like, let's be a gem. And so we were trying to think about all sorts of names. As I said, we were together in a living group when we were at MIT, and we had the gem of the living group was the pearl. So we always wore pearls. So we thought, oh, why don't we be the pearl, something with the word pearl in it for our name. Couldn't quite think of a name that was that great with the word pearl. So we kept thinking, and the Black Opal came up for several reasons. It's one of the rarest gems in all of the world. And one of the things in venture capital is you're trying, you see a lot of companies and you see a lot of pitches, and you're trying to find that sort of gem that's hidden among all of these companies that's going to be, the standout, the most, transformative company in the industry. The connotation that, we're looking for these black opals, these very rare gems in the industry, was something that really appealed to us. The second thing around a black opal is that it's, if you look at it, it has, from one angle, it just may look like a deep colored stone. But the second you start to move it, you start to see these beautiful, brilliant colors. And we really want to kind of bring that brilliance to the venture capital ecosystem, bring in new voices, new people, and bring in a level of, diversity that we haven't really seen in the industry. And so that connotation that this is a gemstone that has these beautiful hidden colors was something that really excited us about the name. Let's find gemstones. We went through the internet and came to the Black Opal, not really knowing much about it, and then realizing it had all these beautiful connotations with it.
We'll dig into some of that. Before we dive deeper, I'd love to get a snapshot of Black Opal today. Maybe start at the beginning with the mission and then go on and give me some of the headlines. I mean, this is an investor podcast, so I want to kind of put bookends around at least what we're talking about, and then we're going to drill down on how you're investing.
Black Opal invests in what we say the collision of healthcare and technology. And so we invest in companies that are either applying or developing highly innovative technology to healthcare and life sciences. And we invest in all the frontier technologies that have applicability in this industry. And that really brings together the two backgrounds of the two founders. So I come from healthcare, Eileen comes from deep tech, and we're really trying to bring together those two worlds. The mission of the fund is to, have significant returns, but have positive impact both on the industry that we invest in and on the venture capital ecosystem. And so that's an important, and I know we're going to talk about some of the initiatives we have at Black Opal, but some of those are really to make sure that we are having positive impact on the world using tech for good.
You've raised one fund, right?
We have, yes.
It was like 58 million, if I'm right. And somehow you pulled in heavy hitters like Eli Lilly on the big pharma side and Bank of America and JP Morgan on the financial side. So how did you and Eileen pull that off? Because that's pretty impressive for the first fund with no track record.
So the fund is actually, yes, we're investing out of our first vehicle. The fund is actually $63 million. As you mentioned, we have these amazing institutional investors, Eli Lilly, Bank of America, JP Morgan. We have two fund of funds, Illumin Capital and New Summit Capital, and then, a number of individuals that have come in. We have two health systems also, Atlantic Health System and Henry Ford Health System, who are investors. And I think, it's very hard to raise as an emerging manager. We were a team that came from experienced in our relative industries, but had never run a fund together. And we, didn't have a track record together. Eileen had a track record from her many years in investing, but didn't have a track record together. Couple that with the fact that it was actually one of the hardest times to raise a venture capital fund. This is 2022 when, the world felt like it was falling apart. It was, we were not seeing returns. It was a very hard time to raise a venture capital firm. And I think the thing that I think resonated with our investors were a fewfold, right? The first was the kind of industry focus and this idea that healthcare, there's tremendous opportunity in healthcare and life sciences and lots of opportunity to solve problems in this industry. And that bringing together industry experience with venture capital experience is, a really valuable team dynamic because we can both identify companies and support those companies as they go out and commercialize and grow. The second thing is, we're one of the rare female-led funds in venture capital. Less than 5% of assets under management go to female-led funds. We are a fully female-led fund. And I think there is an interest. I think we were able to tap into investors who had a very specific interest in supporting diverse managers, but also wanted diverse managers that had, a good amount of expertise under their belt. And particularly Eileen having 20 years of venture capital experience, there are not a lot of women who have 20 years of venture capital experience, was, I think a de-risking for some of those programs that were supporting diverse and emerging managers. And so, I think it was an aspect of some of the strategic nature of it, in the strategic investors and in others who had an impact focus both on industry impact, but also on people impact.
Just for reference, what are your target returns?
We're targeting top decile returns. And, it's an interesting time to think about returns because we did not invest during some of the very hyped up bubble particularly in healthcare and digital healthcare in 2021. And 2020, 2021, where we had, really high valuations, lots of money raised. And so, we're targeting top decile returns, but also investing at a time when, in fact, it's more of a buyer's market and it's more of a time when we have reasonable valuations. And so both, we think that the thesis of the fund and the sector focus of the fund gives us very good opportunity to meet those return goals, but also the timing of the fund is also a good time to actually be in venture capital because you're ideally investing, and we are ideally investing at a time when valuations are reasonable and we can start to see those significant upticks as companies start to really commercialize.
How many employees do you have?
So we have 2 employees. So we have a team of 4.
Is everything in New York or is Eileen in California?
Eileen's in California. So we're a bi-coastal team. Eileen is based in California. I'm based in New York. Our 2 team members happen to be based in New York, but that was just out of coincidence. The point of the bi-coastal team is what is very nice about it is it allows us to cover very different areas. So, Eileen can cover the classic Silicon Valley tech ecosystem. She does a lot of investing around what I mentioned, which was frontier technologies. So technologies that are sort of the infrastructure and underlying layer of sort of the future of healthcare and life sciences, whether it's a graph database or an AI infrastructure platform that then can have applicability to healthcare and life sciences. I'm in the New York area where there's a ton happening in digital healthcare, very close to Boston, where there's a lot happening in the life sciences world. And then we have venture partners kind of all over the country. So we have a venture partner that's based in Chicago. We have a venture partner that's based in London. So we can see some deals from London and Europe. And so we have coverage through sort of non-full-time employees, but partners with the firm.
So let's get into Black Opal a bit below the surface now, and maybe you could discuss Black Opal's theory of change and the problem or the problems that you are trying to solve.
There's probably 3 big areas in healthcare, or maybe 4 actually nowadays. I think there's a 4th one that really plays a big role. When I think about healthcare, and this has been the problems that have existed and the way we frame problems in healthcare for my entire career. And that is cost, quality, and access. So how do we keep control of cost in healthcare? How do we improve access to healthcare? And how do we make sure quality of healthcare is high and strong? And I would say that the other area right now in healthcare that's very interesting and another sort of novel problem is how do we make sure things in healthcare are safe and secure, particularly when we think about data and privacy and all these new frontiers of what's happening in healthcare. There's not one single problem in healthcare that needs to be solved. There's a number of problems in healthcare that need to be solved. They are still very big problems that exist, despite lots of trying to change things. Are big problems that still do exist. And, healthcare is a massive industry. So we spend globally, we spend about $15 trillion on healthcare. In the US alone, we spend $4 trillion on healthcare. And in the US in particular, we spend more per capita on healthcare than any of our peers in Europe, who are spending probably, a half to 2/3 of what we spend in the US. As a result, there's a lot of push to try and figure out ways to deliver care more cost effectively, to make that care more available and accessible to people. And then again, to make sure that we are providing the best quality care, whether it's, the best therapeutics or the best diagnostics. These are all things that many of us are trying to work out in healthcare. And as I said, I've been working in this area to try and improve access, quality, and cost my whole career. What excites me about the startup and venture capital ecosystem is just the way companies sort of take a different approach than legacy players. It's very common in healthcare for big companies, big players to say, yeah, it's a problem, but we don't know how to solve that. And we love finding companies that are really finding those problems and solving that.
When I was researching you, I found that you said you support founders who are building, as you put it, a brilliant tomorrow. So let's talk about this idea of building a brilliant tomorrow in healthcare. That's a big vision. And when you look at the healthcare system today, as you just mentioned, and I think I'm right, you're investing primarily in the United States. So we're probably talking here today more about the US healthcare system. It's huge and it's complex and it's so big. I have lived most of my adult life abroad, but I did grow up in America and I lived part of my adult life in America. And I get the feeling that nobody really understands how it all works. And if anyone does, I don't think they're saying how it works because they're usually making money off of it. What does that brilliant tomorrow actually look like to you, and how do we get there?
I have a very simple definition of how I hope and envision healthcare to be, and agree with you, Scott. It is a big behemoth of an industry. It has so many players, and on the ground when you're seeking out healthcare or healthcare services, it is like a massively daunting, messy process most of the time. But, when I think about and again, having been in this industry, you're right, it's a messy process, but I'm very, I really do believe that healthcare is improving and changing, even if it does happen at a very slow pace. My dream is that we get the right care to the right patient at the right time at an affordable cost, right? And if we can start to do that in ways that make it easy for patients, that is a vision of healthcare that I would love to see. And we do some of that, like that happens in certain situations and certain circumstances, but we have so much more to do. We have, diseases that are untreatable. In this day and age, we should be, we are discovering new ways to treat disease that never were treated before. Things like sickle cell anemia, that we had the first gene editing this year for a condition that we had no way to treat the underlying genetic condition like sickle cell anemia. So this idea that we're developing therapeutics, for example, that can treat patients that we never were able to treat before. We have things in healthcare that are using artificial intelligence to try and help patients navigate their care. So they actually don't find it to be so daunting and inaccessible and difficult to navigate, but we don't have to pay, tons and tons of humans to do that kind of navigation, which can be, frankly, really costly for any kind of organization in healthcare. And so this idea of technology really changing things and helping us think about a future of healthcare is something that really excites me. And in that simple way of like, how do we get the right care to the right patient at the right time and make it affordable?
Simple is good. We can use that. You've described your investment thesis as focusing on the collision of healthcare and technology. So tell me, why does investing in this intersection between healthcare and technology represent for tech innovation versus just investing in a traditional tech-focused VC fund? What opportunities are you seeing there that others might be missing by going into a general tech VC fund?
So, many tech VCs have investments in healthcare and life sciences. I think it is typically part of a portfolio if someone is investing in tech. One of the things that we really focus on is both discerning the kinds of investments that we think are going to do well in this industry, whether it is, as I said, investments that are more of the infrastructure of classic tech that we think have applicability into healthcare and life sciences, or companies that are really purely focusing and playing in the healthcare ecosystem. And the second is really so discerning and understanding the industry to understand where there's problems, where there's gaps, and how these companies can fill the gaps. It takes, there is a level of pattern recognition that happens in any job, particularly in venture capital. And so if you can quickly understand that this is a unique opportunity that this company is tackling, and we know it's going to grow and fill a problem that exists in healthcare, those are the kinds of companies that we are investing in. The second is the value that we help founders with. And as you said, healthcare is one of the most complex, you said nobody really understands it, right? It's one of the most complex industries in the world. And yet it is one of the biggest industries in the world, right? It is 20% of our GDP in the US. As I said, trillions and trillions of dollars spent on healthcare, and hugely impactful for patients and their families. And so we work to really help bring value to our companies, to help them really understand how they commercialize, how you navigate this behemoth of an industry, how you define value for your customers, and how you develop product that is not just tech for the sake of tech, but really tech that is transformative and will be adopted by the industry. And so that specialized expertise that we bring is, I think, that it helps us both identify the best investments, but also bring real value to the table once we have invested in companies.
One of your main problems you identified when we were discussing your theory of change was access. And there's often a perception that improving healthcare access and making it more equitable has to come at the expense of profitability. But you're a VC, you're going after market rate returns. So you're clearly finding investable opportunities in this space. So how do you identify companies that can both make a meaningful impact at the same time generating competitive market rate returns?
So I actually don't think of access as being something that is at the whim of profitability. One of the things that I think about is if we have an access problem, that means there is more market opportunity that exists right now where needs are not getting met. And so access doesn't need to mean that we are providing free care or care at a significantly lower cost. It's that we're providing care for a group of patients or a market that's just not getting the things that they need. And I'll give you a few examples. So we have an investment in a company that is in the obesity management space. So it's a virtual care company called Flight Health. And Flight Health was founded in 2020 by a group of physicians who were practicing at one of the preeminent obesity management clinics in New York City at Cornell. They were sort of one of the founders of the company was actually the founder of the Society of Obesity Medicine 30 years ago, had been talking about this field for years and years, and had been practicing in this area. And that what they found was actually that they were providing this high quality, highly impactful care, but their waiting list was a year long to get an appointment to see them. And what they were able to do was start a company that provided this care virtually, that provided this care with augmented technology to help patients do a lot of self-management, and to use providers that could be guided by experts, but were lower cost providers. And you think about the market opportunity for obesity medicine, it's 50% of the US population is potentially eligible for this kind of care, and only 2% of those patients are actually getting the evidence-based care that they need. That is a massive market opportunity. That doesn't mean that you're necessarily providing that care for free or very low cost, but you're providing high quality, high value care for a very big population. So that's an example where access was a real problem. This company there's still a big market opportunity, but this company is starting to democratize that access in a very high quality way. Another example is a company that we have called Hyro, which is a conversational AI platform that allows patients to call in or use a chatbot to help them find the right provider for them, to help them navigate the care so that they can get in and get appointments and see the right providers for them. That's an area where they're improving access by helping people actually find care, right? Find where there might be appointments available, who might be a good match for them, what's the best kind of care that they may want to seek out. And that's all driven by technology, and particularly by artificial intelligence. And so all these ways that technology is improving access, for example, doesn't mean that it's not profitable businesses, highly profitable businesses, very big market opportunities, also very impactful on that patient and that provider.
But isn't another one of your main points unsustainable cost? It seems like access has a relationship with cost.
It is sort of this triangle, right? If you think about access, quality, and cost, is there a way to find a perfect equilibrium where you're actually providing accessible, high quality care at lower cost? That has been like the holy grail in healthcare for my whole career. We are already seeing technology playing a big role in helping to create that equilibrium of those three. If you can, again, going back to that example of Hyro, if you can get patients to navigate to the right care, you can actually lower the cost of care because they're not doing, ending up in unnecessary places or with unnecessary care. They're actually finding the right care and then getting the right care, as I said, going back to that mantra, getting the right care to the right patient at the right time. You can then improve access and lower cost.
Let's talk now about your investment process. Walk me through how you actually decide to invest in a company. Like if I were a founder walking in your office tomorrow, what's the end-to-end process Black Opal goes through in selecting an investment that gets you to the point to write a check? And you can start with how you identify your investment universe and get the right people in the door,
We source deals from many different ways. So obviously, we both have very deep and broad networks in healthcare and venture capital. And so we're always getting deals from other venture capitalists or from founders who are sending things our way, from industry conferences where we spend a lot of time sort of out and about. But we also have a number of theses that we explore on an annual basis. And we create something called a global competitive analysis. About 4 of these a year are things that we create where we think we have a thesis around an area where we think there is investment opportunity, and we do a very deep dive into that space. So for example, we did a very deep dive into the use of artificial intelligence for the development of new therapeutics. Last year, we did an assessment of the use of AI for administrative tasks in healthcare this year. And so that idea of not just taking what comes our way, but then going out and having a thesis and seeking out investments in that space is a way that we source investments. Once we have an investment that's interesting to us, we have a pretty rigorous stage gate process with new investments. We do a qualitative assessment of the company based on the market opportunity, the unique technology or moat that they may have around them, the traction that they have in commercialization, and the people who are leading the company. But we also do, I think most venture capitalists do this, a quantitative evaluation of what we think the returns can be for that company. And that really is based on what we know from exit markets, multiples in the exit market, how much companies will have to raise in terms of new and future capital. And, we model out various scenarios to give us a sense of what is the worst case scenario to what is the best case scenario when we model out the financials for a company. So it's a pretty rigorous evaluation, both on a quantitative and a qualitative perspective.
Do you perform like an impact assessment at the same time that you're doing the financial analysis? And can you describe what that is?
Yeah, so it is one of our qualitative assessments, is understanding the potential or the existing impact of a company. We look at a few different areas of impact. As I mentioned, we'll look at the impact on cost, on quality, on access, on privacy and security. And that is something that is discussed when we do a decision about a company. Do we think there's going to be positive impact on, health and healthcare for patients or providers? It's interesting because we do have a number of companies, as I mentioned, that are more on sort of the pure technology side of things. And what we have seen is, sometimes people will ask, well, how can a database company have impact? But we think of impact in not just in those very clear things of access, cost, and quality, but that idea of being able to unlock the power of data and the power of technology is really important. I alluded to some of the companies we've invested in. If they didn't have the infrastructure and the technology to do the things they're doing, then they wouldn't have the impact that they have. And so we also see companies that have sort of a step, they may be a step away from direct patient impact, but we see a clear line of sight to the impact that they can and potentially have, particularly with the partners that they partner with.
You say you're addressing global problems, but your portfolio seems to be largely focused on the U.S. Who is your primary target? Is it only U.S. companies?
So we ideally would love our companies to have impact more broadly than the U.S. And we have several companies that in fact do so. We have a company, for example, named Optellum, which is a lung cancer detection company that's based in the UK that sells into the US, but also into Europe and Asia. So has a very broad reach of their technology. We have a company called Conceivable, which is in the IVF space that is looking to go into many markets beyond the US. But what we do find, and even for companies that are outside of the US, from a growth and revenue perspective, the US is by far the largest market. And so in order to actually be a sustainable, highly successful company from a growth perspective, in healthcare, you almost have to come to the US to commercialize. Almost all of our companies have a presence in the US from a commercialization standpoint, but we also, we have networks and support. As I said, we have a venture partner in the UK who can help those companies ideally have more of a global reach. But the truth is that the US is the largest market. And even if you're a non-US company, getting to the US is really important from a commercialization standpoint. And again, one of the challenges is it's a hard system. So, we really try to help those founders, all of our founders, but particularly non-US founders, to navigate the US healthcare system.
Maybe that just means that the US is paying too much.
Well, I mean, we could debate that. There's some evidence, but I've been in the industry a long time. Not that much has changed.
What's your typical ticket size?
So we have two programs in our portfolio. So one is a core portfolio program where we do $1 to $2 million investments in C to Series B companies. Often we're a syndicate partner with other investors given round sizes, but that's our typical check size. And then we have a scout program, which is a smaller checks in typically earlier phase companies where we see potential promise. It may just be early in the company, or it may be before a round is being raised and we want to get to know those founders. So those are typically smaller checks, 100 to 250K.
What proportion of companies that you look at each year end up getting investment from you?
We have 10 core portfolio companies, 8 scout portfolio companies right now. And this is for the lifetime of the fund. We've seen over 2,500 deals in our deal flow. So it's less than 1% actually get investment. I think that is a pretty common number for VCs. It's not, it's not an atypical number, but it is a common number that most deals, the vast majority of deals, don't make it to investment.
It's not uncommon at all. You focus on 5 key areas in healthcare. I think we've kind of touched on some of them, but somehow I've come up with 5. Rising cost, health disparities, poor quality, and medical errors. That's a little bit alarming. And lack of access, and uncured and unmanaged disease. That's a lot of ground to cover. How do you balance all these different challenges?
It is a lot of ground to cover, but I think as we talked earlier, a lot of them, there is a lot of interrelation between these areas. If you can lower cost, you might be able to improve access. If we can treat disease, we might be able to improve quality of care. So there's a lot of overlap, I think, with some of the things like the problems that we're trying to solve. As a focus for the fund, these are the big problems that we see in healthcare, and we like to see companies that are tackling these big problems because that means there's a big opportunity. But we also, we do focus on a few sort of areas in healthcare. We call them the D's of healthcare: diagnostics and prevention, delivery of care, and drug discovery and development are 3 kind of areas that we and another framework of how we think about the focus of the fund. And then as I said, we also have about 40% of our portfolio are all the technologies that allow us to solve these problems, whether it's AI, whether it's cyber, whether it's new computing technologies that allow us to really leverage technology to really impact all these problems in healthcare.
Within these 5 areas, how does profitability interact with impact? And I guess there might be nuances between the different areas. Can you get more impact for your profit buck out of certain of those areas?
I would say there's no hard, fast rule that if you're solving one problem, you'll have better impact and better profitability. I think the key thing is, and this gets down to how you run a business, right? Are you tackling a very big problem with a very big market opportunity? I think that's the first and foremost thing. So big problems that have big market opportunity tend to be companies that have opportunity to grow. The question around profitability starts to deep dive into, who are you selling to and why would they buy what you're selling, right? And this gets to sort of that complexity of healthcare, right? If you're selling to a payer, the value of your product is very different than if you're selling to a healthcare system or to a pharma company. And so understanding the particular value that you're delivering to your customer is, I think, one of the most important things that a startup company needs to understand. Because if you have a big market opportunity and a big problem to solve, but you don't know how to sell to the person that needs to adopt that technology or that product or that service, then you'll go nowhere. And so understanding that you need those nuances of, I think a hospital system is going to buy this. We will often ask, well, why do you think that, right? Is it going to improve their bottom line? Is it going to improve the way they practice, that they will really want to adopt this technology? Will it improve revenue for them? These are all kind of key questions when we think about actual profitability and commercialization of a company's product or services.
Your fund is a little bit young, so I don't know if you've done many exits, but what is your exit strategy?
It's an interesting time right now. The IPO market in not just our industry, but in venture capital in general has been a difficult time right now in terms of exits to IPO. But I think we have several companies in the portfolio where we see a strong potential IPO possibility, particularly, venture capital is a long game. So, we're talking 5 to 7 years from now that they will grow to a point where they will be IPOable. And, we see similar companies out on the market right now that are IPO'd companies. But in general, the vast majority of companies will be acquisition targets. You think about the various pharma companies, device companies, payers, providers that all have strategic reasons and interest in acquiring companies. I think in all sectors of venture capital, the vast majority of exits do happen typically through acquisition. IPOs are more rare, but again, we are always thinking about the companies in the portfolio that if they can, grow and meet their metrics, they will be very IPOable companies.
I'd love to hear about some of the companies that you've backed. One in particular caught my eye was Conceivable Life Sciences, which is doing some pretty revolutionary things with IVF access. But are there a couple examples you could describe what they do and what you hope to achieve impact wise with them?
I'm so glad you brought up Conceivable because Conceivable, I think, is a classic. When you think of a Black Opal Ventures deal, Conceivable is a very, I would say, a prototypical deal for us. It is a company that is using tremendous amounts of technology and really cutting edge technology and solving a problem that exists and is really problematic in healthcare. So this is a company that is creating an entirely robotic embryogenesis lab for IVF. So embryogenesis is the process that we take an egg and a sperm and create an embryo for IVF. Currently, it is done by humans, and it's a process where a human will do very bespoke manual processes to harvest the egg, clean the egg, inject a sperm into the egg, and get the embryo created. And we not just is it a very manual bespoke process, but we have a limitation on the number of embryologists in globally, that we can't actually meet the demands that exist in globally for this field. So, we have a problem where we don't have enough people to be able to do this work, and the work that they're doing is highly manual, highly artisanal, and as a result, it's slow and it may be error prone. And so that idea of actually helping that human do a manual process using a robot is not so unusual. We do it in manufacturing, we do it in so many other industries. This is obviously a hard industry. We are dealing with tiny, tiny cells and, moving cells and difficult to do things. But with the use of visual AI, the use of robotics, the use of all these things that are almost off-the-shelf technologies put together, Conceivable is actually transforming that entire process. And so they are going into a clinical trial this quarter. They've already had many successful embryos created. Their first pregnancy happened this fall, and they're going into a larger clinical trial in the new year.
Well, that's a great story. What about companies like IntelliHealth or Empatica?
Empatica is a company that spun out of the MIT Media Lab. One of the co-founders is a woman named Rosalind Pickard, who is, I would say, one of the pioneers of artificial intelligence, started doing artificial intelligence research and development in the 1990s. She was actually an early professor when I was at MIT in 1990. I think she joined the faculty in 1992, and I was there in the 90s. But she has been one of the people who has really developed the concept of how do you use technology to measure things that are very hard to measure, and then use artificial intelligence to predict what may be happening to someone before something happens. And so one of the things there's lots of things in healthcare that are very hard to measure, things like pain, things like stress, anxiety. We use very rudimentary ways to measure that. Empatica has actually developed over 100 biomarkers that help you measure things, as I said, very hard to measure things, whether it's stress or pain or neurologic activity, all things that can now be measured on a wearable device. And you can take all that data and then make predictions from it. And so Empatica actually has a clinical biomarker diagnostic that actually predicts when someone might have a seizure before they actually have a seizure. It's available to patients, it's available to family members for a condition that is very scary for patients and their family members, but can be deathly if you don't realize that someone is having a seizure or maybe at risk for having a seizure. So that is a device that is being used clinically for a very specific neurologic case. There's more development for other areas around migraine headaches, around depression, of using these new biomarkers to do better diagnostics. And they actually also have a very big portfolio of companies that in the clinical trial space that they work with to be able to do remote clinical trials and monitoring of patients all through a device. So again, a great example of really cutting edge technology having very impactful outcomes on patients, but also a very big market opportunity and great opportunity for commercialization.
You referred to your Scout program. Describe how that works and what made you decide to include that as part of your strategy, because I'm just trying to understand what this is and why you do it.
Yeah, so the Scout program allows us to act quickly and invest in earlier phase companies where we think there's high promise. And it allows us to get to know founders and start to demonstrate the value that we can bring to founders, but also get to know these companies very well before we write a larger check. And, there's, I think, twofold things. It builds a really nice pipeline for our core portfolio and for future funds. So it allows us to have real insights into companies we think are very promising and, then be able to make larger investments later on when they're at a more mature level. But it also gets us into deals that may be hard to get into in the future. We all know that venture capital deals can, particularly as companies start to get more successful, can get competitive. And so if we can get in early on and get to know founders through a small investment, it allows us to hopefully get into more competitive deals. And then the third is it actually allows us to broaden our reach. So our Scout program not just includes the core team, but we have a number of scouts who help us source deals. They are investors in the fund, they are advisors in the fund, and it allows us to get a really good, robust deal flow beyond, what a core team has access to.
In your impact report, you identified a company named Violet that you invested somewhere towards the latter end of 2023. Can you explain what they are and why you chose to invest in this in your Scout fund?
Yeah, so Violet is, as you said, a Scout portfolio company. It's a company that is developing a new way of measuring provider performance, particularly around providers' inclusivity and their ability to care for vulnerable patients. I like to equate it to, I don't know if you're familiar with a company called Health Grades or other ways that we measure provider quality, but it's almost like rating physicians, right? We have a lot of companies out there that help say this provider is good at this and that, and it allows patients to find good providers for them. It allows us to potentially pay good providers more. All of this is happening in healthcare and has been happening for the past decade. What Violet realized is that a lot of the way we rate providers is based on, very clinical metrics, not necessarily all around experience of a patient, and that certain patients need and want unique characteristics of a provider. Whether you are a patient who is looking for a provider who can provide culturally competent care because you may be at risk for having low health equity in your care. That's very hard to find right now in the industry, and find ways to navigate to those patients to those kinds of providers. And so Violet has created an entire kind of, I don't want to call it a grading system, but a metric system for understanding cultural competency and inclusivity of providers based on the kind of care they've delivered, their training, their background. And then they can, provide those metrics to all sorts of organizations that are helping patients navigate care, whether it's a payer or a care navigation company, that all are looking for ways to help patients navigate to the right care.
Technology integration into healthcare comes with unique challenges. And so I'd like to know if you could talk about some of the trickier aspects of health tech. It might be things like getting patients used to virtual healthcare instead of face-to-face meetings, or maybe like getting doctors used to virtual healthcare instead of face-to-face meetings, or perhaps dealing with privacy concerns over digital patient records and so forth. What are these types of issues, and how do you help your companies navigate these challenges?
There is a tendency in healthcare to be resistant to change. I break down technology into a few different areas. I think you've alluded to a number of technologies that help us either deliver or administer healthcare differently, whether it's virtual care, whether it's remote care, whether it's, the ability to write a note without actually having to sit down and type it out on a weekend. These are all the things that happen in healthcare that are sort of behind the scenes. I always go back to, what's the value that you are bringing? When you think about technology we'll use that last example of saving doctors and providers time by not having them have to sit down and type notes. The reason those things get adopted is because you actually, you may be able to have more patients be seen in a day. You may be able to fight physician burnout, and you may be able to, again, kind of lower the cost of delivering care to patients. So with that idea that, yes, technology is very hard to integrate sometimes into healthcare. But if you can actually show a real value proposition of that technology, that's when you start to see adoption. And again, the value for the customer depends on the customer and the value that you can bring. So I think that there's, as you said, there's aspects of cultural changes that have to happen in healthcare. And the idea of virtual care is a great example where, I'd actually been writing about virtual care as being a potential way to deliver care better and more cost effectively for decades. And there was no adoption of virtual care until COVID hit. And all of a sudden we had this moment where people said, oh, we can deliver a lot of care virtually. We don't actually have to deliver care in person. And sometimes it may take something like that, a very big change that can happen, whether it's policy, whether it's something that's happening in the environment that pushes people to make a change. Those are ways that sometimes we can get adoption of technology. As I said, value proposition is really key. And then I would say the third area in healthcare is there a way to get things reimbursed or covered in healthcare? We see a lot of technologies that are on the clinical side of things where, amazing technology, and yet we don't know if a payer will pay for that. And if you can't get that to get paid for, it gets very hard to adopt. So often when we look at these companies that are still early in trying to figure out product market fit, and whether they, if they're a new enough technology, whether a healthcare player will adopt it, we think about all those things, like what's happening at a macro level, what's the value that you have, and, is it going to be able to get integrated through a reimbursable model, all sorts of things when we think about how you actually get these things adopted. And that's why we do love to see, early product market fit, because, I think a key thing is not investing in tech just for the sake of tech, but investing in tech that really has product market fit.
Are your investors exposed to any other unique risks that are specific to your strategy as opposed to general market risk that every investor is exposed to?
Healthcare is a highly regulated industry. And so I think having, this goes back to, is there unique value of being a specialized fund? This is one of the unique values of that, is understanding sort of the key factors of that regulation, whether you're regulated by the FDA, whether you are providing clinical care, all of these are areas where, regulation plays a role. It is, as I said, a highly regulated industry in general. And so, we are very, I think, knowledgeable and cognizant of any potential risks that may happen because it is a regulated industry. And I think our investors put their trust in us because we have the expertise to be able to do so.
So let's talk about measuring impact, because it's one thing to say we're improving healthcare and access and all that good stuff, but it's quite another thing to prove it. You described for me that when you're doing your financial assessment and qualitative assessments before you go into an investment, you do some kind of quantification of impact. How do you actually quantify and measure the impact to, let's say, healthcare access your portfolio companies are making post-investment? And are there any KPIs that you watch in general or specifically?
Yeah, so measuring impact is harder than you think it can be. And of this is that each company impacts the industry in very different ways. And so the way we think about it is we think about the categories of impact that a company may have. So we mentioned things like, how does it impact access or quality of care, or, data security. All of these are areas that we start to think about the areas of impact for a company. And then we think about specific ways that they may be impacting patients both directly or indirectly, whether it's the number of patients that they are able to touch or impact, whether it's the actual outcomes of something, particularly if it's clinical, how many lives were saved or conditions were treated. And so we take sort of a bespoke method of looking at impact at a company level. We spend a lot of time with the founders when we draft up our impact report to understand, again, the areas that they are potentially impacting and how they are thinking about the impact that they have. So whether it's, again, access to care, or how many patients had more accessible care because you had this service available, or if it's cost of care, like how many dollars were saved because you didn't have to pay for something more costly. Each of the ways we measure impact is at sort of a company bespoke level, but again, thinking about high level categories where we know there's problems in healthcare that need to be impacted.
This problem is exacerbated by startups are, by definition, pretty lean. What is the quality of the data that you get? Because I'm sure they don't have a staff to measure impact.
And that is exactly right. Some of these companies haven't, they don't have the funding or the resources to do, for example, a clinical trial or something very expensive and costly like that. But one of the things we do help our companies do, and I think they've been very grateful for, is the ability to kind of tell that impact story and put together the pieces of, how am I thinking about the impact of my, there's some that are very obviously impactful companies. And then there are others that we help them really, we really help them understand the impact story that they can tell.
How does Black Opal support its portfolio companies beyond providing capital? You've referred to engaging with founders. How do you maximize both profitability and impact with your founders? What is it that you do for them?
Yeah. So, we've talked a lot about how we measure and support impact stories for companies, but one of the big areas we focus on, and this gets to that idea of revenue and profitability, is helping our companies commercialize. So we have an entire commercialization program where we spend time with the companies understanding their go-to-market strategy, all the way from who are their customers, do they understand their customers, do they understand how to price, and who's supporting, who are the people in the organizations that are helping them to commercialize. Because at the end of the day, a company needs to generate revenue. Generating revenue in healthcare is, it's a big opportunity, but it's a really complicated industry to generate revenue in, as you know. That's probably the biggest area where we spend most of our time with our companies, is helping to commercialize. And we do that through formal programs, strategy sessions with founders, workshops with founders, and a broad network of advisors and colleagues that help our companies understand and meet and network into the industry. So that's one area. The second is we do have a component. Part of our fund is to try and build a more inclusive venture capital ecosystem. We don't have any mandates or any quotas for the types of founders or the demographics of founders that we invest in, but we also want to be able to help our founders identify talent that may not be on their radar and help them get the tools and the resources to be able to build diverse teams and workforces, reduce bias in their product. And so we have another arm of our value that we bring to the table is helping founders think about the diversity and the potential bias of products and all of these things that have to do with diversity in the ecosystem.
One thing that stands out to me about your approach is how you've integrated diversity into your core thesis. And it doesn't seem to be just a nice to have, but it's a crucial tool for success. So what I'd like to know is, what is the connection you see between diversity and finding better and faster solutions to healthcare problems?
Yeah, so I think in healthcare in particular, the value of having different viewpoints is so critical. I think about, for example, companies where, perhaps an entire leadership team or board may not have diverse backgrounds or demographics or vantage points. And you can get very pigeonholed, I think, into thinking about things in a very narrow way. And so again, we think about how these companies, diverse viewpoints, both at the management team, at the board level, really help these companies be more creative, be more nimble, and think about potentially the end customer, which at the end of the day is often the patient in a much more thoughtful way. As I said, we don't have a mandate or a percentage or anything around the types of founders we invest in. But one of the things that we do like to do and is help them, I think for the first time, often they may not hear this from other venture capitalists, but like, how can we help you round out a management team or build a board that has diverse viewpoints so that you're getting all the best information and all the best resources and building the best products for the patient, for the provider, for the industry, because you have all those people around the table.
Can you talk about how you've seen healthcare access disparities play out in your medical career, and how does that influence your investment decisions now?
I've seen lots of issues in access to care throughout my career. Earlier when we were talking, I told you about, the times where in the early 2000s, I had, all these uninsured patients that didn't have any access to any health insurance, couldn't access any care. We've come a long way from that because of policies in the US. Obviously, in other countries in Europe and the UK, there's single payer systems. They function in very different ways than the US healthcare system. But, this idea of a patient not being able to afford something and that may be life-saving or life-altering for them is, a real tragedy in healthcare. And so when I look at companies, I think, again, if we can find ways to get people covered better in terms of the kind of insurance they have, if we can lower the cost of care, all of those things can really, and if we can get better technology and tools to be able to do so, all those things, I really believe can be improve access, improve equity, and still be very profitable revenue generating companies.
Well, how do you see technology helping to bridge these access gaps?
Lots of ways, right? I think, again, we have a lot of things in healthcare that are human driven. Healthcare, if you go back, decades, healthcare was, a doctor and a patient sitting in a room, writing notes, making a decision, maybe getting paid by the insurance company. So many things have from a technology standpoint have changed that, right? For example, electronic health records. As I said, I didn't have electronic health records when I started practicing. Electronic health records have transformed our ability to understand holistically what's happening with a patient. We can see what happened when they saw a different doctor. We can see their lab work that happened a year ago. All these things that have really transformed how we care for patients, all technology driven. Now we're in an age where AI is really taking over a lot of that, right? And in fact, the idea of AI helping a patient find the right care, or AI helping a patient get a diagnosis at home rather than having to go to the doctor's office, all ways that we're improving access to care, lowering cost of care. And the real underpinning of that is technology.
When I look at your portfolio, it seems like your portfolio companies show significantly higher representation across gender and racial diversity than what one would expect from a typical venture capital portfolio. How have you managed to achieve that?
Part of it is, the founders of the firm. We are a female-led, minority-led firm. We probably resonate well with companies and founders that are also, maybe not the most common demographic for a venture-backed founder. I also think that, we look for companies that I think the impact focus does probably bring in a demographic of founder that is thinking about profitability and impact at the same time. As I said, we don't have a quota or a demographic focus for our founders, but I think just because of who we are, we've been able to find amazing founders of all demographics and are really, excited about the things that they're doing.
What barriers do you still see in the VC world when it comes to improving diversity, both at the investor level and in portfolio companies?
I've actually spoken about this at a few different events on, particularly around, we know, for example, that female founders just do not get the same amount of capital that male founders do. There's lots of data on that. And so the question is, Why is that the case? I mean, are these companies just not as strong as other companies, or is there something that is happening from a bias or representation perspective that we are just not aware of? I often tell female founders, like, there is probably some implicit bias in there that is making it harder for you to raise your capital from venture capital. And there's probably things that you just have to be able to recognize, like go straight to like, financials and revenue and, things that like that really resonate with venture capitalists, rather than potentially, telling a story that doesn't get to that quick enough. The other is, I think it is in all jobs, and particularly in venture capital, there is a lot that comes from, networking and understanding, who's in your network and how you meet those people. If less than 5% of venture capital dollars are actually allocated to female funders, female venture capitalists, that means that female founders have to get capital from many different, from non-female funders, generally so, right? I know a lot of women who've started women's health companies, for example, and they've had to kind of define and describe the women's health problem that they're trying to solve to like a room full of male VCs. Really hard to do sometimes, right? You're starting from scratch to describe what menopause is, right? Like these are very hard things for a female founder to do, where, if you're in a room with a female VC, they're like, yeah, I got it. Like, tell me about what you're doing and how much money you're making, right? And so, I think there are some of those challenges that exist where explaining the problem may be hard to do, making the case may be hard to do, and the people across the table are just a different demographic as you.
Do you know Sharon Vosmick at Astia?
I don't.
It'd be good for you to meet her. Maybe I'll put you together. She's been on the show before. She only invests in women-led companies, but I think she's coming back on maybe later this week or next week. She has a lot of data on this. And she has some pretty interesting stats on how much we could improve GDP by just having more investment going into women-led companies. But she pulls no punches about why it happens, and quite humorous. She'll talk about white guys sitting in the room, and then they only meet the other guys who come from the same place, same school they come from. And then they get together and talk like, yeah, he was a good guy. No, yeah, I like that guy.
Yeah.
Yeah.
And
she's,
right. I mean, that's
got a big
human
thing
nature, right?
that you're not in the conversation. You never get a chance to be in the conversation because those conversations all happen in private.
I mean, that is so true, right? The concept of networking or not even networking, but no, your network is typically more similar to who you are, right? And if every venture capitalist is a certain demographic, then that's not necessarily the network that you're going to go like hang out and play golf with, right? Like,
Where is Eileen based? In Menlo Park or Palo Alto?
Yeah, in San Carlos, but yeah, in the Valley.
I think Sharon's up in San Francisco. I'll put you maybe in touch afterwards.
We invest in any founder, right? If you have a great company, we want to invest with you. We also want to be on your board. So you have some women around the table, right? Like that's like unique value that we bring, right? And, we have several companies that are fully male management. I sit on the boards of 2 of those companies. And, I think we have an incredible board rapport, I think, because we have we have diverse boards, and we're often the people who are like, I don't know, wonderful that you have this management team. Maybe you should make sure that the slate that you are hiring for your next, C-suite person is a little broader so that you actually are not only looking at the people that just look like you. So, I think those are the things that we've heard is like, oh, no one actually mentioned that to me. I'll do that next time. When I'm hiring someone, I'll make sure I look broadly, and can you help me with that? So yes, it is a more nuanced approach, but what we find is that, we have founders who for the first time will say, oh, I hadn't even thought about that. And thanks for bringing it up.
I'll put you guys together because you should know each other, because that's her big thing. And she's very outspoken about it and pulls no punches on it. So listen, I'm curious about the role of government in all this. Healthcare policy can be such a hot button and often a political issue, especially in the United States. How do you think about what the public sector's role should be in advancing health tech innovation?
So I would actually say healthcare government role is probably even bigger outside the US, but it's big everywhere, right? In every country, the government plays, at least every developed country, the government plays a very big role in healthcare. In the US in particular, the areas that we see the role of government is reimbursing for technology. The biggest payer in the US is Medicare, which is the payer that covers older adults and people with disabilities. So largest payer in the US. And often what will happen is if Medicare says this is new technology is really valuable, we think it's good for patients, we'll cover it, we'll pay for it. It then trickles across the entire industry. And so that payer and reimbursement policies have such a big role from a government perspective, actually, on what gets covered in across the industry. Often private payers look to what public payers are covering to make those decisions. The second is, not just how we pay for healthcare, but how we regulate healthcare plays a very big role. And, regulation of new technologies in healthcare is often done by the FDA. What we're seeing now is we have this whole new world of particularly artificial intelligence that we now have to, I don't know, I don't have a crystal ball to understand where 10 years from now that will be regulated, but anything that's touching a patient and the decision making of a patient, I think it starts to fall under that question of, is it a regulated technology? We have, for the past 10 years, have had something called software as a medical device, which is a regulated FDA approved, if you are developing software like Empatica, for example, that has wearable software, you have to get FDA approval to say that that technology is actually helping to diagnose and you have the evidence to support it. So there's two areas where policy plays a really big role, and that is around reimbursement, around regulation. And then, the third area that policy historically has played a big role is around healthcare IT. And that often comes in the form of ways that we incentivize the use of better healthcare IT. The US has an entire group called the Office of the National Coordinator for Healthcare IT that does a lot of work to try and improve the use of software and information technology in healthcare. So policy plays a very big role. And if you look at like all the big changes that have happened in healthcare and, monumental changes, often there's a policy push that has driven that.
Looking ahead, what gets you the most excited about the future of health tech, and what innovations do you think could really change the game for the type of companies that you're investing in?
So I think it's hard to talk about health tech without talking about artificial intelligence. I equate this, I went to school in the 1990s before we had the internet. And I remember distinctly in 1995 or 6, like one of my friends saying, have you heard of the World Wide Web? And sitting down and like learning about the internet, you move on to then, how phones have transformed our ability to gather and understand information. I think AI is going to be, again, one of those monumental shifts in technology that we're already seeing value from, but it's going to continue to play a huge role in healthcare. And we see a lot of that right now, and all these things where AI is helping us do things that were like so painful to do, like writing notes or, billing an insurance company, like all these things that AI is able to do now, all the way to like helping us make better clinical decisions for patients. And, I think it's going to continue to be a big, big area where it's like the new frontier. What's interesting to me is that we now are at a point where I think healthcare's, adoption of tech is very hard to do in healthcare, but we're actually seeing adoption of AI in healthcare at rates that I haven't ever seen before. And I think that's going to continue. So, it's hard to be an investor in this space and not think about the role that AI is going to play in health tech, whether you're excited or scared about it. But then, what's interesting, and it brings up a whole nother set of things, like how do we then make sure we're doing we're using AI responsibly? How do we make sure data is secure and private, right? Like it just brings up opportunities for new and more companies because you've opened up sort of a Pandora's box of all sorts of things that can happen. So, we think there's a lot going on around AI, but also what's going on around all the things that are needed to responsibly use AI in healthcare.
What could be wrong with ChatGPT handing out prescriptions,
Right, right. And, we're playing in a new world. We just aren't going to go back. So I think what we get excited about is if the future is going to be in that direction, what's healthcare going to need to be able to adopt these technologies responsibly? And again, we have a number of investments in the AI space we're super excited about because we're seeing adoption rates that are tremendous and much higher than 5 years ago. But as a result, we're also, carefully looking at things like cyber companies and others that are trying to also protect the use of all that AI.
Tara, I've got a few rapid fire questions for you before we wrap up here. So just give me whatever comes to your mind, or if nothing does, feel free to take a pass. That's okay too. But if you had to name the one most important challenge in the health tech impact VC investing space at this time, what would it be?
Curing uncured diseases. Like we're in an age where I think we should be able to cure cancer and we haven't yet. So I still think we have a lot of potential there to treat things that we can't treat yet.
What do you know now about health tech VC investing that you wish you knew back in 2021 when you founded Black Opal Ventures?
That fundraising is harder than I thought. We were very lucky to have an early anchor investor, and it took us a long time to get other institutions on board. I've learned a lot about sort of the entire investing ecosystem, which I wasn't really a part of before 21.
Fundraising is never easy.
There's no fun in fundraising is what I often say. Both fundraising and venture capital is an overnight success. You're starting with companies that are tiny, right? And they have to grow a lot and it takes time.
You don't have to name names, but can you describe an investment you made that you were convinced of at the time that it ticked all your impact boxes, but in the end it didn't turn out? And what was the lesson learned from that experience?
We're fortunate that we haven't had anything that's like really blown up. But I think the biggest thing, and again, this always gets back to like, how do you sell into healthcare? I think there's companies that have amazing technology, highly impactful. They should be paid for. We should adopt it. And it is so much harder than you think to get those things adopted. And that is a thing about investing in healthcare that you have to always have your mind on is like, okay, I know this is good for patients, but we won't always pay for it. And we have to understand that route to payment. So, I think getting adoption can be slower than you think.
And has this happened with any of your portfolio companies?
Yeah. I mean, again, getting reimbursement, getting someone to pay for it is always harder than you think.
Were you surprised by it? Like it's been surprisingly slower than you thought? Because you know this.
Yes and no. Yes, I should have known. It's always harder to get, but in the reality of the day, it's always sort of humbling to see how hard it is. And I worked on the payer side, right, where I was making decisions about things that were covered or not, and you realize being on the other side of trying to get coverage, it's humbling to see how hard it is sometimes to get reimbursement.
So my next question is on the flip side of this. Can you describe an investment that you had some skepticism about, either at the time you invested, or maybe you were so skeptical you ultimately passed on it, and in the end it turned out way better than you thought, and either you're really happy you invested in it or you're disappointed that you didn't? And what was the lesson learned from that experience?
Every venture capitalist has companies they passed on, and then those companies did well. I feel like we all keep a running list of like, oh, I passed on that company, and then they just raised around, and with these great investors at this high valuation, like every single person has that list in their mind. I think for me, one of the challenges is sort of suspending reality when I look at companies, because I come from the industry and I have a level of skepticism where I'm like, no one will buy that product. Like, I don't, like no one's going to adopt this. And then a founder proves me wrong. There's a running list of things where I'm like, I never thought that would be a big company and they'd be able to sell that product that they actually did. I've definitely have a running list of companies like that again, I think come a little bit from like maybe I'm a little too, too founded in reality. Sometimes I think there's a little bit of like, I have to suspend a reality a little bit because actually this could be a very big thing. And I would say I think again, going back to that AI topic, 3 years ago, I had a pretty high skepticism of the adoption of AI in healthcare. I thought that we've been talking about the use of AI for decades. Like for 10 years, we've been talking about how AI is going to transform healthcare, and it hasn't really happened. And then, in the last 2 years, there has been a real transformation of the use of AI in healthcare. And so, that's another area where it probably took me a little longer to get over my skepticism because I've seen it be so hard. So these are, I think, again, real benefits of coming from industry, but sometimes I may be too much of a skeptic of things.
If someone wants to get into the health tech impact VC investing space, where would you advise them to start and cut their teeth?
I don't know exactly. Like I had a very unusual career path. I think most people come from the venture capital world and sort of move up the ranks of associate to, they move up the ranks at a firm. I took a very different career path. I have a lot of doctors, for example, who come to me for advice on how do I get into this world? And I often say like, well, how much do you want to practice and leave medicine, right? That's a big change. And so for people who are in the healthcare world, for example, which is like a lot of the people I know, I tell them to like start advising, like start working with startups, start working with venture capital firms if you can, and provide insights to them, because we're all looking for knowledge and connections in the industry. And that's a wonderful way, if you're coming from industry, to think about getting involved in this ecosystem.
Tara, it's been great speaking with you, and you've been very generous with your time, and we've covered a lot of ground here. I think this is true. It's the first deep dive into healthcare that I've done on this show. But thanks so much for taking me through all this. Learned a tremendous amount today. So why don't you tell everybody how they can learn more about all the great things you're doing at Black Opal Ventures, and how can they find you?
Easiest way to find us is our website, blackopalventures.com. And we're very active on LinkedIn. So you can see all the things we're doing on LinkedIn, all the activities of our portfolio, and sign up for our mailing list. We send out blog posts pretty regularly about things that are happening in the industry and with their portfolio.
And the best way for people to contact you?
So through our website is the easiest way to contact.
Said everybody go to blackopalventures.com. There's lots of good information there, and you can find out everything that Tara's doing. So, all right, Tara, thanks again.
Thank you, Scott.
All right, goodbye, everybody.
You've been listening to SRI 360. If you enjoyed it, please hit the like button and subscribe to get future episodes. You can find an archive of all previous podcast interviews and more articles and information on SRI, ESG, impact investing, sustainable investing, and socially responsible investing at our website, sri360.com. If you'd like to read more lessons learned from world-class SRI investors, get a copy of Scott Arnell's book, Sustainable and Responsible Investing 360. It's a must-read for anyone wanting to know more about investing for positive social, environmental, and ethical impact, all with market financial returns. These are the stories and tactics of those leading the way as sustainable and responsible investing goes mainstream. Sustainable and Responsible Investing 360 is now available in hardcover, ebook, and audiobook format wherever books are sold.